Glycemic control can be assessed by HbA1c, capillary blood glucose monitoring, and continuous glucose monitoring, or CGM, often used in combination. HbA1c reflects average glycemia over 3 months, and it has a strong predictive value for diabetes complications. However, it may be less reliable in people with conditions that alter red blood cell turnover, or hemoglobinopathies, end-stage renal failure, or recent blood transfusion. CGM metrics of time in range, or TIR, and glucose management indicator, or GMI, are surrogate markers of HbA1c that can be used to guide clinical management. Published data suggest a strong correlation between time in range and HbA1c, with a time in range goal of 70%, time below range of less than 4%, and time below 3 millimoles per litre of less than 1%, aligning with an HbA1c of approximately 7%. Although HbA1c is the primary measure to guide glucose management, the TIR and GMI provide more insight into day-to-day glycemic control and allow for a more personalised diabetes management plan. The HbA1c target should be individualised based on patient and disease features such as risk of hypoglycemia and other drug adverse effects, duration of diabetes, life expectancy, and the presence of established vascular complications and other comorbidities, in addition to patient preference and what resources and support systems are available. Studies have shown that an HbA1c of less than 7% reduces microvascular complications, especially when instituted early in the course of the disease. Aiming for an HbA1c of less than 7% is recommended in non-pregnant adults with absent or minimal established complications and who have a low risk of significant hypoglycemia. Ideal preprandial capillary glucose values for many young, non-pregnant individuals are between 4.4 and 7.2 millimoles per litre. Postprandial glucose may be targeted if HbA1c is high, despite reaching preprandial glucose goals. For older adults who are otherwise healthy, with few coexisting chronic illnesses and intact cognitive function, it is reasonable to aim for an HbA1c of 7 to 7.5%, while for those with multiple coexisting chronic comorbidities, cognitive impairment, or functional dependence, a reasonable target would be an HbA1c of less than 8%. For individuals with end-stage chronic illness or reduced life expectancy, an acceptable glycemic target may be relaxed further, where the focus of therapy would be to avoid hypoglycemia or symptomatic hyperglycemia. In summary, glycemic targets should be individualised based on patient characteristics. A target HbA1c of less than 7% is appropriate for many non-pregnant adults without significant risk of hypoglycemia. For older adults with coexisting chronic illnesses, a less stringent HbA1c of less than 8% may be acceptable.